Today's topic is very important. And if you've solved the free MCQ1 questions, you realize that this is a very important objective you need to understand. And the objective, I'm getting the objective from the question. In fact, those in the MedCognito program, you realize that we've done a whole lecture series on this for you. And I'm not surprised that the Medical Council dropped the question. So we're going to use this question, and then we're going to use we're going to build teaching points out of that. So let's try this question. You have a 78-year-old woman who presents to your clinic after she's found to have a 2-centimeter hypoechoic thyroid nodule on ultrasound. She feels well and does not report hoarseness, dysphagia, or hyperthyroid symptoms. Now, her medical history includes type 2 diabetes and hypertension. She has never had head or neck radiation, and there is no family history of thyroid cancer. Her thyrotropin, which is thyroid stimulating hormone, level is 0.1 MIU per liter, and the normal range is 0.34 to 5.6. Which of the following is the best next step? Which of the following is the best next step? A, computer tomography of the neck. B, thyroid antibody levels. C, free needle aspiration of the thyroid. D, repeat thyroid ultrasound in 6 months. And E, thyroid uptake and scan. So what is the correct answer? And remember that we are going to build on these 5 answers for tonight's class, because thyroid nodules is a very, very important MCC objective. Thyroid nodules is a very, very important MCC Q1 objective. So please, what is your answer? Is it A, is it B, is it C, is it D, or is it E? So keep the answers coming, keep the answers coming, keep the answers coming. Okay, good. So I'm very glad that we are solving this question. And I'm going to show you the reason why I'm saying that. Doctors, what's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? And you have to understand that there are principles behind it. So whatever answer you are choosing, you must understand the principle behind it. You must understand the principle behind it. Now, before we answer this question, I'm going to do something. I'm going to share my screen and then let you know why the Medical Council dropped this particular important topic. Okay, so please, if you can see my screen, you realize that why are we focusing on thyroid nodules tonight? If you look at the objectives of the MCQ1 exam, there's an objective which is called neck mass, goiter, and thyroid disease. And when we are done, I'm going to send this. Let me send this link to you so you will understand all the details and the nuances you need to know so far as this particular objective is concerned. So doctors, I'm sharing the link in the comment section. Okay, why are we focusing on this objective? Because it is in the MCC objectives. It is in the MCC objectives. It's in the MCC objective. So I'm sharing the link right now in the comment section. Please click on it because that is what we are focusing on. Now, the Medical Council says the majority of neck masses are benign, but it is important to distinguish those that are rare ones which are malignant. Now, what are the causal conditions? We have benign conditions like congenital thyroglossal cyst. We have inflammatory conditions like reactive lymph nodes. We have neoplasms like lipomas. And then we have malignant neck swellings like thyroid problems, non-thyroid head and neck cancers, and lymphoma, right? And the key objective is that given a patient with a neck mass, the candidate will diagnose the cause, the severity and complications, and will initiate an appropriate management plan. Particular attention should be paid to exclude malignancy. Then they go on to say something interesting. Given a patient with a neck mass, the candidate will list and interpret critical clinical findings, including an appropriate history and physical exam, paying particular attention to number one, risk factors that predispose to malignancy, for example, smoking. Number two, the time course. Number three, the presence of pain, swallowing or systemic symptoms. Number four, signs or symptoms of thyroid dysfunction. And then they go to two, list and interpret critical investigations, including recognition that no investigation may be necessary, investigation of thyroid function, and diagnostic imaging. And then they go to the third point. And so you realize that the question I dropped is focusing on this part, diagnostic imaging. Then they go to the last part where they talk about this very important thing, that construct an effective initial management plan, including reassurance and appropriate follow-up for suspected benign lesions. Number two, appropriate medical management, for example, thyroid stimulation, antibiotics. And number three, referral for specialized care like fine needle aspiration if necessary. Doctors, you see, I always tell people that the exam, everything you need for the exam is staring at you. Everything is staring at you. And look at the way the medical counselor has put this so beautifully. So let's go back to the question. Then you come to understand why the question we put there is important. So what answers are you going for? Let me see. Some people went for C. Dr. Benedicta Glover went for C. Another one went for C. Then Dr. Joanna De Cruz went for D, which said repeat thyroid ultrasound in 6 months. And then Dr. Teddy Ansah went for E, which says thyroid uptake and scan. Okay. And then Dr. Michello went for C. And so this is the beauty about this whole thing, that I really want us to pay attention to certain things. These are free questions the medical counselor has made available. So if you are not getting the free questions right, it is telling me something, that a lot of us as doctors are not reviewing those questions. A lot of us are not reviewing those questions. That is why I've taken it upon myself to take these questions and break them down gradually. Okay. Again, please, doctors, for example, Dr. Therapy and Healing 001. It looks like you are viewing the thing with and you see this way on your computer. You see this way. Go to the MedCognito YouTube link, and you realize that there's one which allows you to see it this way. I'll change the settings so that we don't have both showing. Okay, but I just wanted to draw your attention to it. So, doctors, back to it. Back to the question. Okay, back to the question. What is the correct answer? The correct answer is E. And I'm going to take my time, because of the nature of this objective, to deal with this particular topic very well. The correct answer is E. So if you chose A, B, C, or D, they are all wrong. The correct answer is E. That is thyroid uptake and scan. Now, you also realize something, and success leaves clues. Look at the reference material the medical counsel is using. Just go to the base of this before you even read what I have up there. Just go to the bottom. And you see, that is why I always say that, look, use the appropriate materials. The medical counsel, the material they are using to source a lot of their questions It's uptodate.com. It's uptodate.com. Uptodate.com, July 8th, 2024. There's a whole lesson on thyroid masses and how to evaluate them. That is where they are getting it from. Okay, and then another source they also get their concepts and base their questions on is CMAJ, Canadian Medical Association Journal. Doctors, it is staring you in the face. And that is why you realize that when you come to MedCognito, I always say that, look, please make sure that you are using the appropriate studying material. Okay, so now that I've said all that, let's go to the details to know how we're going to break down the concepts. Doctors, I have a question, please. So far, are you seeing why this topic is important? Are you seeing why it is good that we take our time and break these concepts down? Doctors, please, if you are seeing it, just type yes, yes, yes for me in the comment section. Are you seeing why it is important? Please. If you are, just type yes, yes, yes. Number one, I'm showing you where they source the stuff from. And that is why me, if anyone asks me, I always say, look, please use up to date. Use up to date. And use the Canadian Medical Association Journal. Make sure you're using, choosing wisely. Make sure you are using for your ethics, doing it right. Make sure that apart from doing it right, you are also using CMPA. This is the source the Medical Council goes to. And in their free questions, they are showing you. Okay, so what is the rationale here? And how are we going to remember how to deal with thyroid nodules right from the word go? Number one, the first principle is this. In any patient with an enlarged thyroid gland, serum thyrotropin measurement and neck ultrasonography is recommended in all patients with a thyroid nodule. And you will ask me, why did the Medical Council quote this? Let me share the up-to-date flow chart for you to see something. Let me share the up-to-date flow chart for you. Let me share the up-to-date flow chart so you'll be able to appreciate what I'm talking about. Let me share the up-to-date flow chart so that you will appreciate what I'm talking about. Look at this. Doctors, look at this. When it comes to thyroid nodules, according to up-to-date, thyroid nodule, which is found clinically or incidentally noted on imaging, the next best step is TSH and thyroid ultrasound. Doctors, this is how the Medical Council wants you to think. So just by focusing on here, you've already dealt with the first point they are making. The first step in a patient with an enlarged thyroid gland, no matter what, is that I am going to check my TSH and my thyroid ultrasound. And you realize that that is exactly what they also say in their review, in their explanation for that particular question. Then, please, this one, if you can even take a screenshot of this, because every question I'm going to ask from here will depend on the information shared in this slide. So the first best step for an enlarged thyroid gland is thyroid ultrasound and TSH and thyroid ultrasound, those two. Now, if you have a question which states that there is suppression of the thyrotropin level, if the thyrotropin level is low, the next best step, because don't forget that the patient has an enlarged thyroid, your next best step is you're going to get your thyroid ultrasound and your TSH. Now, the next best step is for you to ask yourself, is the TSH elevated or is the TSH low? according to the source that they source this thing from, if TSH level is low or suppressed for your board exam, your next best step is a thyroid scan with iodine 123. And that is why in that question, let's go back to the question again. 78-year-old woman presents your clinic after she's found to have 2-centimeter hypoechoic thyroid nodule on ultrasound. So that means they've already done the ultrasound. So that's next best step. Number one, they've done the first thing. She feels well and does not report hoarseness, dysphagia, and hyperthyroid symptoms. Her medical history includes type 2 diabetes and hypertension. She has never had head or neck radiation, and there is no family history of thyroid cancer. Her thyrotropin, which is the thyroid stimulating hormone level, is 0.1. So that means that they've done the first level, which is TSH and ultrasound. They've dealt with that one. So after you have a patient who has had TSH and ultrasound, the next question you should ask yourself is the TSH elevated in the question, or is the TSH low? According to the source that you need to use, if TSH is low, the next best step is a thyroid scan with iodine 123. Doctors, please write this down in your box. Okay, so somebody says I should share the link to the objective. Okay, I'm sharing a link right now. Doctors, please, I really wish that this thing is opening your eyes to certain things so that you can walk confidently into the exam and make sure that if there is a thyroid nodule question, my first point is I'm going to get my ultrasound and my TSH. After the TSH and the ultrasound is done, the next question I have to ask myself is the TSH elevated or is the TSH low? If TSH is low, the investigation I need to do, I need to write this in my book, is I'm going to get my thyroid scan with iodine 123. Done. Now, if the thyrotropin level is normal or high, then what you need to do is to do a fine needle aspiration biopsy. Doctors, please, this is very simple. For your board exam, don't think twice. This is like we doing med bullets, right? It's like med bullets. And this is how med bullets is. So number one, next best step, enlarged thyroid, is do TSH thyroid ultrasound. Now, next best step after TSH results are released, if TSH is low, next best step is thyroid scan with iodine 123. If TSH is normal or elevated, next best step is fine needle aspiration biopsy. Doctors, please, are we all tracking together? Are we all tracking together? Now, why is CT scan and follow-up thyroid ultrasound in 6 months not a good option? CT scan is inappropriate because the patient has no family history of thyroid cancer and has never had neck radiation. Therefore, if the question had told you that this patient had a family history of thyroid cancer or the patient has had neck radiation before, then you would have requested CT scan. Okay, Dr. Marie says I should repeat. I'm going to repeat. I'm going to take my time and repeat. Doctors, first things first, you have a patient who comes to you, thyroid, you see a neck swelling, you think you do your physical exam, you think it's a thyroid gland which is swollen. The next best step is do your TSH and your thyroid ultrasound. Now, after that, go to the next step. Ask yourself, is the TSH elevated or is the TSH low? If TSH is low, next best step is thyroid scan with iodine 123. However, if TSH level is normal or high, next best step is fine needle aspiration biopsy. Next point, when is CT scan ever considered important in evaluating a patient with thyroid enlargement? Number one, if the patient has a strong family history of thyroid cancers or thyroid, a strong family history of thyroid cancer, or if the patient has had radiation to the neck before. Doctors, please, am I making sense? I beg you. I want to make sure. This is very important and this can be very tricky. And that is why I'm taking my time. That is why I'm taking my time. That is why I'm taking my time. Are we all on the same page, doctors? Please, I want to move on to the next slide, but I want to make sure that we are all on the same page. TSH, thyroid ultrasound. Next step, what is the level of the thyroid TSH? If TSH is high or normal, we do our biopsy. If TSH is low, we do thyroid scan with iodine 123. Okay, good. Good. Looks like now people are picking it up. Okay, so now let's do a deep dive. Based on what I have taught so far, let's do a deep dive into thyroid nodule concepts so that no question can beat you. Okay, so now based on all that we did, you have a 65-year-old man. He is found to have a 1.8 centimeter thyroid nodule on ultrasound. His thyrotropin level is 6.2, which is elevated. I've already taught you. So now you're going in as somebody who is informed. He has no radiation history. What is the most appropriate next step? A, thyroid uptake and scan. B, fine needle aspiration biopsy. C, repeat ultrasound in 6 months. D, computer tomography of the neck. And E, thyroid antibody testing. I'm so happy. You see, now people are Dr. Safwa 7624, Dr. Manes, everyone is now getting the thing correct. Aha. This is what happens if you are properly trained. Good. And Dr. Rockefeller, he says he's going to choose B because the TSH is elevated. Simple. So what is the correct answer? B, fine needle aspiration biopsy. Doctors, look, this is how you prepare for this board exam. You pick the concepts, you break them down, and then now you apply the principles. You pick the concepts, you break it down, you make sure you understand it. Now you apply the principles. Okay, now let's go. So fine needle aspiration and biopsy, that is the correct answer. Why? Because we learned that if you do your thyrotropin level and it is normal or elevated, it indicates a non-functioning thyroid nodule, which requires fine needle aspiration for cancer evaluation. For cancer evaluation. What does this doctor saying? Your patience to explain is awesome. Sure. Doctors, look, we are doing this for you. MedCognito is for you. That is why I love doing these sessions. Okay, now let's go to another question. The same concept. We are just going to play around it so that tonight when you go to bed, you know that when it comes to evaluating a patient with a thyroid enlargement, it's not just the regular, hyperthyroidism. What are the features of hyperthyroidism? And then you just rattle it. No. The medical council always wants to test the well-prepared candidate. So now let's look at this question as well. A patient with a thyroid nodule has a suppressed thyrotropin level. What does this most strongly indicate? So this time I'm not asking you What's the next best step? If you have a patient whose thyrotropin level is decreased, what does it indicate? A, high probability of thyroid cancer. B, diffuse autoimmune thyroiditis. C, autonomously functioning thyroid nodule. D, metastatic thyroid disease. And E, a need for immediate biopsy. Doctors, please write your answer. Write your answer. I'm waiting for your answer. I'm waiting for your answer. Please write your answer. Please write your answer. Let's make preparing for these medical board exams ridiculously simple. Okay? So, the correct answer is C. 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 A low thyrotropin level suggests that the tissue of the thyroid gland is hyperfunctioning. It's working autonomously. Okay, and it looks like the negative feedback reaction is not affecting it. And if you have a low thyrotropin level, which suggests a hyperfunctioning thyroid, it means that this is really a cancer. Okay, good. Next question. Which patient with a thyroid nodule should proceed directly to fine needle aspiration without radionuclide scanning? So you have 5 patients in your endocrinology clinic. Okay, now which of them are you going to do fine needle aspiration without radionuclide scanning? A, low thyrotropin and a thyroid nodule of 2.5 centimeters. B, normal thyrotropin and a thyroid nodule of 1.5 centimeter nodule. C, suppressed thyrotropin with palpitations. D, low thyrotropin with tremors. And E, suppressed thyrotropin with weight loss. Doctors, give me an answer. Give me an answer. Give me an answer. I'm waiting for you. Give me an answer. Give me an answer. Give me an answer. I'm waiting for you. So if you thought that I was just going to say what's the next best step, but no. Now if we are taking the whole concept and I'm mixing it up just a little bit so that I can be able to tell, okay, who is picking up the concept really well. That's what I need you to know. So that's why we've taken it a step further. Okay, that's why we've taken it a step further. So I see a lot of B, and the correct answer is B. So which of these 5 people directly needs fine needle aspiration? Remember we said those who need fine needle aspiration are those whose TSH is either normal or high. That's what we said. That's what we said. That's what we said. And that is what is playing out. So if you chose A, or if you chose C, or you chose D, or you chose E, it is wrong. Okay, good. So normal thyrotropin with 1.5 centimeter nodule. Why? Only low thyrotropin you have to scan first. If the thyrotropin is low, that's when you have to do the scanning. If it is normal or high, then you want to do your biopsy. Okay, next question. Next question. Which of the following is the least appropriate initial investigation in an asymptomatic patient with an incidentally discovered thyroid nodule and suppressed thyrotropin? Which of the following is the least appropriate initial investigation in an asymptomatic patient with an incidentally discovered. So that means all these investigations, some of them are high priority, right? But which of them is the one, the last one, the one you will not want to do? My goodness, Dr. Asfia Khan is just nailing it. She's just nailing it. Good. Therapy and healing, nailing it. Dr. Rumed, nailing it. And the correct, the answers are thyroid uptake and scan. B, repeat thyrotropin in 6 weeks. C, thyroid ultrasound. D, CT scan of the neck. And E, radionuclide scan with iodine 123. The question is, which of the following is the least appropriate? And the correct answer, drum roll, is D. 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 So love life with Jane. You got it right. Dr. Benedicta Glover. So it looks like people have people have understood the concepts, and that I can sleep tonight. Doctors, it looks like with that first slide, which explained everything, many of us have now come to appreciate the concept very, very, very well. So please, thyroid nodule questions cannot beat you. So CT scan is not part of the initial thyroid nodule evaluation unless there is invasive disease or airway compromise. Dr. Vitalia as well got it right. Dr. Vitalia, remember when you were joining MedCognito, I told you that eventually, very soon, within 2 weeks, you will be grappling the concepts like that. Okay, this is what is going on. Okay, next question. Why is fine needle aspiration not indicated initially in patients with suppressed thyrotropin? Why is fine needle aspiration not indicated initially in patients with suppressed thyrotropin? A, the test has poor sensitivity. B, the risk of bleeding is high. C, the nodule is likely benign. D, the nodule is likely hyperfunctioning. And E, antibody status must be confirmed first. What's the correct answer? Okay, so I see a lot of doctors are going for D, D, and the correct answer is D. Hyperfunctioning nodules are rarely malignant, so radionuclide confirmation is required first. Is required first. Please remember, always remember the MCQ one. You are being quizzed on next best step, least important. Next best step and least important. Next best step and least important. Okay, good. So, doctors, with what we've studied today, now I'm going to give you a homework. 10 areas you must focus on so far as thyroid nodules are concerned for your board exam. Number one, you can take a screenshot of this. And for those in MedCognito, please, Dr. Rockefeller, or one of you should please take a screenshot of this and put it in our WhatsApp group. 10 areas you must focus on so far as thyroid nodules are concerned for your board exam. Number one, you must focus on initial evaluation of thyroid nodules. Number two, you must focus on what is the role of thyrotropin as the first triage test. Okay. Next question or next topic you need to also pay attention to is that you must pay attention to interpretation of suppressed versus normal versus elevated thyrotropin levels. Number four, another area you must master for your board exam, the QE1, is indications for thyroid radionuclide uptake scanning. Number five, definition and behavior of autonomously functioning thyroid nodules. Number six, cancer risk stratification based on thyrotropin level. And then number seven, indications for fine needle aspiration biopsy. Number eight, when imaging modalities are inappropriate in a patient with a thyroid enlargement. Number nine, appropriate use of thyroid antibody testing. And number 10, avoiding premature invasive testing in endocrine nodules. These are the 10 areas you need to master when it comes to thyroid gland enlargement. 10 areas that you need to master. And for those in MedCognito, it's been done for you already. Right? Good. So now, doctors, let's do active recall. By the way, please, doctors, I have a question. Today's class, I'm sure when you had thyroid, oh, hyperthyroidism, hypothyroidism, they have tremors, they have lead lag, they have lead retraction, they have exothermos, they have palpitations, they have increased appetite, they have some form of diarrhea, they have decreased skin on this, decreased hair on the skin, and then when it goes to hypothyroidism, they have bradycardia, they have cold intolerance, they have loss of the outer one third of the eyebrow, and you thought that was what we were going to discuss. No, the medical council has a way of quizzing you, and that is what I'm trying to focus on now. Okay, so now let's do active recall questions. What is the first laboratory test that must be ordered in every patient with a thyroid nodule? What is the first laboratory test that must be ordered in every patient with thyroid nodule? Please answer. Let's go. Please answer. Let's go. Please answer the question. Therapy Mama. Therapy and Healing 001. Please remember, it is TSH. TSH is the first one. Don't even go. And then, yes, and I see some people writing TSH and ultrasound. Please be careful about the question. The question says, what is the first laboratory test? Laboratory test. Ultrasound is a radiological test. The first laboratory test. So it is thyroid stimulating hormone. Simple. You move on. Okay? Thyroid stimulating hormone level. That's what you want. Now, next question. What is the correct next investigation for thyroid nodule with low thyrotropin? Next best investigation for a patient with a thyroid nodule with low thyrotropin. What's the correct answer? Based on what we studied today and based on where the medical council wants to place emphasis, what is the next investigation for a thyroid nodule with low thyrotropin? Okay. Thyroid scan, beautiful, 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 beautiful. Thyroid uptake and scan with iodine 123. Simple. Doctor, so now thyroid nodules cannot beat anybody. Thyroid nodules cannot beat anybody. Next question. When is fine needle aspiration biopsy indicated in a thyroid nodule? When is fine needle aspiration biopsy indicated in a thyroid nodule? When is fine needle aspiration biopsy indicated in a thyroid nodule? Okay. See a lot of answers. I see a lot of answers. And the answer is when thyrotropin level is normal or elevated. Oh my goodness. Normal or elevated. That is it. Normal or elevated. Then that one, you're going to do your fine needle aspiration biopsy. Next one. So, doctors, what are my take-home points for tonight's class? Number one, if there is low thyrotropin level, do your scan first. Number two, if there's normal or high thyrotropin level, do a biopsy. Number three, hyperfunctioning nodules are rarely cancerous. And number four, computer tomography CT scan is not a screening test for thyroid nodules. CT scan is not a screening test for thyroid nodules. Doctors, I bring the class to an end. Tonight, you can sleep in peace, knowing very well that when it comes to this objective, where is the objective? When it comes to the objective, this objective, I'm going to share my screen. When it comes to neck mass and thyroid disease, when it comes to the evaluation, nothing is going to beat you. Nothing is going to beat you. Okay? Nothing is going to beat you. Oh, Dr. Aline, don't worry. The questions will be on YouTube right now. As soon as the class is done, it will be there. So please, you can go and review it right away. Okay? Good. So doctors, this is my phone number. As I said, tomorrow I'll not be available. So if you want us to talk, call me right now. +1 306 891 5649. +1 306 891 5649. +1 306 891 5649. Let's get talking. You can join MedCognito. You can decide to make a one-time payment of just 2,200 Canadian dollars, get access for 6 months. Or you can decide to pay monthly payments of $420 every month for 6 months. But remember, if you make a one-time payment, you are saving almost $350, right? But doctors, the choice is in your hands. Thank you very much. I will make sure that I leave this video on and you can repeat it. Thank you for spending your evening with me. God bless you. I appreciate you. Share the link with as many friends as possible. Let them review. And always remember, use appropriate study materials. Don't forget up to date at all. Okay? Don't forget up to date. Someone say something. I'm going to join you soon, Dr. Bonnie. Thank you. Sure, that's fine. Okay? Doctor, so if you want us to talk, please, 3+1 306 891 5649. +1 306 891 5649. Especially, I prefer WhatsApp so that whether you are in Canada or not, I can still reach you. Thank you very much, doctors. Thank you. All the best. Good night. Say hi to your loved ones, and we'll meet again on YouTube. All the best. Bye-bye.